So I have the lovely pleasure of introducing Dr. Elizabeth Malinzak. She is an assistant professor at Duke University, where she serves as the director of medical student education for the Department of Anesthesiology. She attended medical school and residency at Duke and pursued a pediatric anesthesia fellowship at UNC. Dr. Malinzak is also chair of the American Society of Anesthesiologists Committee on Young Physicians and serves as an applied examiner and MOCA question author for the American ABA. She is current president of Women in Anesthesiology. As a pediatric anesthesiologist, her interests include fasting guidelines and adults with pediatric diseases. Her other academic interests include advocacy for women in medicine, medical education and simulation, social media, and leadership development. Today, she will be giving us a talk on fasting guidelines, the challenges, controversies, and corroboration. We welcome you, Dr. Malinzak.
Thank you so very much for that very kind introduction, Dr. Diaz. As I pull up my presentation here, I would just want to say how excited I am to be presenting virtually to all of you today. There's many of you that I follow on Twitter. Social media is an interest of mine. And so I am actually live tweeting my talk today. So you can follow along there as well, or find the key points later on. I also want to say, just briefly, I give a very shout out to my former resident, who's now one of your faculty members there, Dr. Annie Castro. She texted me very early this morning and said she was going to be busy doing blocks, which I totally get. Everyone has their own different areas that they're working in. And so the nice thing about virtual talks is it gives you a little bit of flexibility, but you guys are really lucky to have her. She is quite amazing. So today I'm really excited to be talking to you about fasting guidelines. And this will be an interactive talk. So I will have some polls that will pull up every now and then. I do have no disclosures for this talk today. And the way I got interested in fasting guidelines is really actually from my social media interests. You see all these posts from people on Facebook and the various groups saying, help, my patient ate X. What do I do? How long do I wait? Like, do I need to wait? What's the reasoning behind it? And so I just found that very intriguing. I wanted to know more about what's the evidence behind our ASA fast guidelines. So today I'm going to discuss a little bit about the risk of aspiration, as well as the effects of prolonged fasting on our patients. We'll discuss the literature and the evidence behind the ASA guidelines, as well as the other various specialty society guidelines. In order to do that, we will also chat a little bit about gastric emptying and the complex phenomenon it is. Gastric ultrasound has become very important now. As a pediatric anesthesiologist, I am no means an expert in gastric ultrasound, so I'll only touch base on this very, very briefly. There are other people out there who are more experts than I am on that topic. And then last, we'll close with discussing some controversies and challenges, as well as some fun stories about NPO violations. So we are going to have a few cases that I'll discuss during the course of the talk today. And all of these are real situations. So they're either cases that myself or a colleague or a friend of mine at another institution has experienced, just to bring a little bit of real life to this presentation today. So the first case is a 67-year-old male who has hypertension and type 2 diabetes, who comes in with a hip fracture after a fall. And of course, ortho sees him and they say, we got to take him to the OR the next day, put him on his first case. So he is made NPO at midnight in preparation for his case at 7 a.m. Unfortunately, there's a lot of other orthopedic procedures that come in, maybe, a major motor vehicle accident. So other emergency cases that delay his case. So by the time he gets to the OR and is induced, he's not had anything by mouth for 16 hours. So once you induce him, you notice that he's hypotensive. His MAPs drop to the 40s almost immediately, and you're having to give high-dose phenylephrine in order to support his blood pressure to a MAP of 65. So if we can bring up that first poll question, please. Excellent. So First poll that I'd love for you all to answer is, until when would you have permitted him to have clear liquids? Would it be 7 a.m., 5 a.m., midnight, 2 hours prior to induction? So I'm going to give you all a minute to submit your answer. All right, I'm going to say last call for answers here. All right, and we will go ahead and close the poll, and let's see what these answers are. So about a quarter of you said 5 a.m., 10% said midnight. Most of you said 2 hours prior to induction, and none of you said 7 a.m. Awesome. So what actually is the answer here? I actually don't know the right answer. This is kind of a bit of a trick question, to be perfectly honest, because there's a lot of variability in this. Yes, ideally, we want the patient to have clear liquids until 2 hours before induction. That's following the ASA guidelines. That's best practice. That helps keep our patient hydrated. The problem is, when you have emergency cases, you don't know when the patient is going to be induced, or they may be switched to another OR. So that makes it very challenging to set the cutoff time period then. No, NPO before midnight, that's probably the easiest thing to do for all of our patients, because the surgical patients are on various different services who are coming to the OR. There's a lot of different interns who are writing the diet orders. They don't exactly understand about what it's like and why patients need to be fasted before surgery. So making it clear cutoff NPO before midnight, that's probably the easiest thing to do. Maybe a compromise might be 5 a.m., as many of you answered, because that's 2 hours before the earliest time the patient could be induced. If you think that's the earliest time that the patient's going to go. That being said, he also has diabetes, and we know a lot of have gastroparesis that could potentially increase his risk for aspiration. So there's a lot of factors to think about here. But the key thing that I want to point out is that we are so focused most of the time about the fact that we're going to delay induction for a patient and delay the efficiency of the operating room because we let a patient eat or drink before surgery. But let's flip that around. Let's look at it from the other perspective. Our patients are probably fasting for too long. For this patient to go 16 hours without something to eat or drink, that's a really, really long time. So let's pull up our second poll question here. Which of these may be a consequence of prolonged fasting? Increased thirst, insulin resistance, delirium, anxiety, or all of the above? So I'll give you all a few seconds to answer that as well. All right, the last call for answers. And we will go ahead and close that out. Awesome. Okay. 93% of you answered all of the above. I have to say this was a bit of a softball question after that first trick one. So yes, the answer is all of the above. So the various effects of prolonged fasting, we know that when you prevent a patient from having something to eat or drink, yes, of course, they're going to be thirsty and they're going to be hungry. That's what patients complain of most frequently in the pre-op area. A lot of times this thirst and this hunger can contribute to a patient's anxiety before surgery. So they're already anxious about having the procedure, but when they can't have anything to eat or drink, or they've been fasting for a really long time, that might make it worse. You may see some signs of dehydration, such as dry mucous membranes, although it has been shown that that's reduced if you allow those clear liquids up until 2 hours before induction. Insulin resistance has also been seen, and we know that's associated with poor surgical outcomes. We do see in certain patient populations decreased blood pressure. There is conflicting information on this. So in healthy patients, without any comorbidities. We usually don't actually see any hypotension after induction contributed to prolonged fasting, but we definitely see it in those who have a lot of comorbidities and those at extremes of age. And there was a really good study that showed that in children that was published just a little bit while ago. And then there's also some evidence that post-op delirium can be probably because of prolonged fasting, although the jury is still out on that, and there needs to be some more evidence. So how often does a prolonged fast actually happen? I'm happy to attribute this slide to one of our current residents, Dr. Brian Chow, as he took this upon him to do a QI project, looking at our patients at Duke and how long our inpatients actually fasting. So he looked at patient populations for non-emergent inpatient cases who are undergoing non-cardiothoracic surgery, and then examined how long the patients were fasting from being made NPO to at midnight to their time of induction. And for reference, of course, ideal circumstance, what we always aim for, give our patients clear liquids prior to induction. What we found for our inpatients is that the mean time was 12 hours. The minimum fasting time was about 7 hours. And the maximum fasting time was almost 24 hours. I can't even imagine going 24 hours with food, especially when you're sick in the hospital. So this is surprising. It's a lot more than I think anyone expected. So it is true. A lot of hospitals have NPO policies like Duke that are much stricter than our ASA guidelines. And as I said before, this is often due to convenience because it's just easier to tell patients and to tell the physicians who are providing the orders to make the patients NPO at midnight. There was a 2016 survey in Michigan hospitals. 100% of them had policies around being NPO prior to surgery, but only 25% of them actually were compliant with the ASA guidelines. The other thing that we have to consider is that often patients choose to fast longer than we tell them to, especially if they're outpatients. So this is a picture that I took off a website of a surgical that's telling patients this eat or drink before surgery. These are things that could potentially happen to you, and that you should refrain from food and fluid for 6 to 12 hours prior to your surgery, unless your doctor tells you otherwise. So a patient who maybe is nervous about their surgery is Googling things, because we know everyone always does that, all of our patients do. Why can't I have anything to eat or drink? Googles and finds this picture, which honestly was very easy for me to find. It was second things that popped up on Google Images. We'll read this and be like, wow, anything bad to happen to me. So even though they said I could have clear liquids up until 2 hours before I arrive, maybe I should just wait a little bit longer just to make sure that I stay safe, because I'm super nervous about anesthesia. All right, so second case here. This is a 16-year-old female who was otherwise healthy, who had ornathic surgery. She was nervous about having her jaw wired for 6 weeks straight. So she decided to have a big final last meal, eating a cheesesteak with fries. This morning she met NPO criteria. She had a 4-hour procedure. And then when she woke up, she had some nausea and she actually vomited profusely in the recovery room. Liquid was coming out between her wires. And then she was complaining of having fries in her mouth. So despite the fact that she actually met the policy of this particular hospital, and she had a procedure without any aspiration operatively in the recovery room, there was still food coming out of her stomach from the night before. So aspiration, it happens in about 1 in 2,000 to 1 in 4,000 general anesthetics. That's about 0.0005% of all general anesthetics that we do. Pretty rare to happen. That being said, when it does happen, it can have some very devastating consequences, which is why we are all worried about it. So when we look at the closed claim data and the claims made there, aspiration represented 5 claims. It was 115 cases out of 2,500 cases total. And in those aspiration cases, there was a judgment of substance made in 60 of them, with a median payout of about $50,000. And of those 115 claims, 66% in death and 60 were in death and 16 in severe injury. And 60% of the patients who made these claims also had risk factors for aspiration, such as GI obstruction or an acute intra-abdominal process. And the most likely time of aspiration to occur was on induction of general anesthesia. So hence the ASA practice guidelines for fasting to reduce the risk of pulmonary aspiration. So the guidelines were written in 1990 initially. They were revised in 2011 and then in 2017. And I'm not sure how many of you have actually read these word for I've read them many, many times, and it is very, very clear in the introduction to the guidelines that these are not an absolute standard. They are simply guidelines to follow. They cannot guarantee any specific outcome. They're only written to reduce the risk of aspiration, that clinical outcome of aspiration. And third, they only apply to healthy patients undergoing elective procedures. There's a notable list of many other things that are considered risk factors for aspiration that these guidelines cannot predict and can not guarantee anything for these patients, that you need to, as an anesthesiologist, make a judgment about what is the best case scenario for patients with these other issues that are going on. Second, it is clear when you read the methodology of the guidelines that there's very limited peer-reviewed research that's out there that shows any evidence of reducing that clinical outcome of aspiration. So most of the guidelines and how they're derived actually come from consensus opinion and expert knowledge about gastric physiology. So we're going to talk a little bit about gastric physiology. Traditionally, gastric volume and pH have been used as a surrogate endpoint for aspiration. And the thresholds of 0.4 mLs per kilo for volume and a pH of less than 2.5 are derived from lab and animal studies, excuse me. So now we use gastric ultrasound a lot more. So you would think that that would help us further define the threshold for aspiration. The ultrasound studies that I saw of animal studies also see that 0.4 to 0.8 mLs per kilo as a threshold. And in patients, generally 1.5 mLs per kilo is the most accepted threshold. And this is on the 95th percentile gastric volume in fasted patients for elective surgery, which corresponds to about 100 to 130 mLs in the semi-average patient. There's a lot of variations in gastric volume, and that's because it depends on various things. It depends on salivary secretions, it depends on gastric secretions, it depends on the oral intake, and it depends on the gastric emptying rate too. So gastric elimination is a complex phenomenon in itself. It's regulated by neural, hormonal, and paracrine pathways. It's controlled by the energy content of the food, and of course, altered by many different conditions like stress or anxiety that our patients have undergoing surgery, temperature, medications, and medical conditions. For solids, we know that lipids have over twice the energy content that proteins and carbohydrates do. So gastric emptying is the slowest for lipids, with proteins being in the middle and carbs being the fastest. So the data here that's shown in this table is for a low-fat egg meal that's undergoing a gastric emptying scintigraphy study. And that, sorry, that if you hear my dog, his name is Remy Sentinel, by the way. Apologies for that. For a low-fat egg meal that consists of egg whites, toast with jam, and water. So it shows that after about 1 hour, you still have 90% even with a low-fat egg meal. And then after about 4 hours, there's about 10%. So again, I do apologize for my dog if you hear him barking in the background. My kids are getting ready for school and now he is barking at them. All right, moving on to our next slide. So we know that higher calorie meals do take longer to empty, as shown in this diagram. And emptying times can be affected by medical conditions like gastroparesis. So you see in red, that's that low-fat egg meal. Higher fat meals, higher calorie meals are going to take longer. Lower calorie liquid meals take faster to empty. For milk, we know milk is semi-solid as a curd when it's in an acidic environment like the stomach. And the studies that I found showed that residuals are actually largest with non-human milk. So breast milk empties the fastest, but even so, that still varies by age, because when an infant is born, At a newborn, there's lower lipid content, so it's much more easily absorbed and passes much more easily. And as the infant ages, the casein to whey protein ratio changes, so gastric emptying actually takes longer. For formula has a really variable composition, so it's hard to say what exactly the emptying is like for this. And clears, the fastest emptying are those that are isoosmolar, pH neutral, and have no calories. And there's still a bit of variability among clears as well. Just so you're aware, the half emptying time water is about 30. All right, so the ASA guidelines, like I said, the literature that they use really concentrates on what the clinical outcomes are on pulmonary aspiration. So they do include randomized controlled studies and observational studies that look at solids, breast milk, and formula. And all of those compare fasting for less than 4 hours to greater than 4 hours. And they were equivocal for both gastric volume and pH to figure out if there was any difference on pulmonary aspiration. So the overall conclusion that they make is that there's really insufficient literature. We don't have enough to tell us what exactly we should do for fasting time. So that is exactly why FASA is among experts, and their knowledge about gastric physiology is the basis for our 2 hours, our 4 hours, our 8 hours, or 6 hour rules. The other I want to point out about the ASA guidelines is they do say consider both the amount and type of food ingested. So, a lot of times your patients will say, well, I just had one bite of this. And normally I ignore it. Well, if they have one bite, they probably have a bowl because I can't trust them. But we do outline in the guidelines that it is very, very important to consider the amount and the type of foods ingested when you're making a judgment about how long a patient should be fasted. So we're going to pull up another poll, our third poll for today. All right, so how many hours until a patient, oh, excuse me, I think I skipped one. Let's hold off on that poll. I think I need to go to the next one. Sorry about that. One more case, and then we'll pull up that poll. Sorry about that. So the 21-year-old nonverbal autistic male who presents for CT under general anesthesia. He had solids prior to midnight. He did take oral contrast 3 hours ago, and he had a sip of water 1 hour ago. Then you take him to radiology after he is adequately NPO, and he takes a large bite out of a foam pillow immediately prior to induction. So now we can pull up that poll because I'm interested in what everyone thinks about how long you should wait before instead of general anesthesia in this patient. All right, so 0 hours, 1 hour, 2 hours, or 6 to 8 hours. All right, I'll give you all another few seconds to answer that. All right, if we go ahead and close out the poll. Oh, all across the board. So about a quarter of you said 0 hours, 13, 1 hour, 10% 2 hours, 20% 4 hours, and 30% 6 to 8 hours. I love the answers of this because, again, I have no idea. This is crazy. What do you do after a patient eats a foam pillow? That being said, as a pediatric anesthesiologist, I've had patients eat some really, really weird things. And so to get a nonverbal autistic male to the CT scanner for general anesthesia when otherwise adequately NPO and does something like this, I would probably just go ahead and induce him. But it's hard to say what the right thing is in this scenario. Get to the next slide. All right, so we've talked a little bit about the ASA guidelines, but I wanted to pull up all the other other specialty society guidelines so you can see how they vary. Now, they're all based on the same evidence, and all of them say that there's insufficient literature to really make a complete determination. And so they all, again, rely on expert opinion to determine what their guidelines are, but you can see there's slight variations in all of them. So I want to point out a few of them. Only the ASA and the Canadian Anesthesiologist Society use an 8-hour rule for solid food. Everyone else uses 6 hours. The other interesting thing is that some of the societies use 4 hours for formula. And then clears, just see what else they put in a clear category besides just water. Some of the societies include tea with milk, or chewing gum without swallowing, or chewing tobacco. I really like that the European Society of Anesthesiology includes a phrase that says that you can smoke until induction. I just have visions of their patients in pre-op, like sitting there and pre-op smoking. That's just something that would never happen here in the United States. And then the Australian and New Zealand College of Anesthetists are the ones who most recently updated their guidelines in 2021 with some really interesting additions. So as I talked about with breast milk being more easily passed as the baby is younger and then taking longer as they age, they have made that designation. They say 3 hours for breast milk if you're less than 6 months old and 6 hours if you're greater than 6. The other really interesting thing is they allow 1 hour for clears for children only. And this is in line with a lot of other pediatric anesthesiology societies who in 2018 released a statement saying that they encourage their patients to have clears. This happened a year after ASA had most recently revised their guidelines. And a big reason why this statement came out is because in 2017, the Apricot study was published. And that was a multi-center study of thousands and thousands and thousands of patients in Europe. They were all children. They looked at general anesthetics and the operation and other clinical outcomes. And they included both unfasted and emergency patients, as well as fasted patients undergoing general anesthesia. They found an incidence of 9.3 out of cases in terms of aspiration. And that's 0.00093%. That's still extremely, extremely rare. So that was the first reason. Pulmonary aspiration is still a rare event in kids. Second, a lot of the gastric emptying studies, when they compare 1 hour of clears versus 2 hours of clears for NPO status, there's no difference in gastric volume or pH. Third, we know with that 2 hour rule, there's often non-compliance. That means that these patients, these kids can often be NPO for 6 to 7 hours. And if any of you have kids yourself, you know when they get hungry, that is a very, very bad thing that you do not want to experience. There's a lot of irritability and they're just like, it's tough to deal with. So reducing the fasting time will make our patients, especially our pediatric patients, just much happier. There have been some studies that have shown that increased gastric residuals are only seen if fasting times with clears are less than 30 minutes. So there's various specialty societies that felt that having an hour for clears was very appropriate. All right, so everyone says a clear is something that you can see through, but just for fun, definitely heard some patient stories about designating some of these items seen here as clear because technically you can see through them. But in general, clears are thought to be water, juices without pulp, coffee with or tea without milk but with sugar added, or complex carbohydrate drinks. So we're going to play a little game called Clear or Not Clear. So if you can pull up the next poll, please. And I'd love for you to go through and say what you think about some of these items. Protein carbohydrate drinks, if they're a clear or not a clear. Chicken broth, if they're a clear or not a clear. Jello, that's a perennial favorite to debate. Or gummy vitamins. And then go lightly. So I'll give you all a few minutes to answer that. All right, I'm going to say last call for answering the poll. All right, there are those answers. Okay, so protein, carbohydrate drinks, most people thought not a clear. Chicken broth, most people thought a clear. Jello, most people thought a clear. Gummy bears, everyone is split about 50-50. And go lightly, most people say is a clear. All right, so we're going to go through those. First of all, those protein carbohydrate drinks. So in general, glucose-containing fluids do initially leave the fluid more slowly than water, but after 90 minutes, most studies show that the stomach is empty of clear liquids regardless of the type. We also know that patients who drink carbohydrate-rich clear liquids until 2 hours prior to induction to anesthesia have less thirst, hunger, anxiety compared to patients who drink water. But these protein-containing carbohydrate drinks, two popular ones, Boost Breeze, which has 9 grams of protein, and Ensure Clear, which has 8 grams of protein, both of them contain that whey protein isolate, which is a milk ingredient. So the studies I found with these show that gastric emptying or residual gastric volume was unchanged when proteins or lipids were added to the carbohydrate drink. And then there was one more additional study that showed that when you added protein to a preoperative carbohydrate drink, that it increased the time to return to baseline gastric volume from 2 to 3 hours. So yes, most institutions are considering these protein containing drinks as 2 hours like a clear, but the jury's still out there. It might be that 3 hours might be more appropriate. Chicken broth was the next one. And honestly, the answer is it depends on the broth. So as you can see here, if you have dry bouillon that has no protein and fat, that's Swanson chicken broth that you buy off the shelf that has less protein than Ensure Clear. But if you look at the ingredients of canned chicken broth and homemade chicken broth, there's a lot of protein and a lot of fat. So it definitely depends on what the ingredients are, what type of chicken broth, as opposed to whether you're going to consider it in that 2-hour rule or if you need to fast longer. All right, that perennial favorite to debate, Jell-O. I put the slide on here to show you that we really just need a study, any study, to help us figure out what the gastric emptying is about Jell-O. There's really nothing on PubMed about it at all. What we do know is that Jell-O is made of gelatin, and gelatin melts at room temperature. So it is thought to dissolve in the stomach at body temperature. And in fact, I did find one study that compared gastric emptying of gelatin to glucose and found that they emptied at the same rate. But just like broth, there are many different compositions of Jell-O. So box Jell-O and homemade Jell-O have about 2 grams of protein and that gelatin. So it seems more similar to those protein-containing carbohydrate drinks. Store-bought Jell-O has 1 gram of protein, the gelatin, a bunch of other additives, but seems to also fall into that 2-hour category. The issue is when you run into some different types of vegan Jell-Os or things where you really need to look at the ingredients. Some types of these desserts are made of carrageenan or of pectin. And these are, despite the fact that they have no protein, they are solid at body temperature. So that means they're going to be solid in the stomach, and they'll be solid if they're aspirated in the lung. So I did not find any carrageenan studies, but I did find some gastric emptying studies done with pectin. And the pectin is shown to cause significant prolongation of gastric emptying half-time of both liquid and solid meals. So despite the fact that we don't have a lot of real literature about Jell-O, I've talked to you about the composition of them. I've given you my best guess, but it is still really confusing because when you Google NPO guidelines for Jell-O, you pull up some healthcare institution websites. This is one from an anesthesiology department in an academic institution. And what they're telling you here is that gelatins are actually should be 8 hours, even though I really couldn't find any gastric emptying studies that showed that. But that apple jelly, which has pectin in it, which I did find studies that showed that that really prolonged it past 2 hours, that apple jelly you can do for 2 hours. So there's so much conflicting information out there, especially when patients are looking for it. And proving this, there was a study done by Roughhead in anesthesia and analgesia, and they looked at all these online fasting recommendations and found that the majority of them are frequently inconsistent with our current ASA guidelines, particularly among healthcare institution websites. So this is a problem not only for our patients, but also for us when we're trying to figure things out. All right, so continuing on our gelatin journey, gummy bears and gummy vitamins. I looked at ingredients of so many different types of gummy bears and found that they're all made of gelatin and sugar and like corn syrup, things like that. And then gummy vitamins, though, their composition does vary. It can be pectin, or they can be made of gelatin too. So it's really important to look at the ingredients of those if for some reason your patient has a gummy vitamin on the morning of surgery. That being said, even if gelatin, from what I could find from gastric emptying, appears that it probably empties in 2 hours, so, and all of our gummy bears are made from gelatin, there can still be risk from gummy bears. I found some really interesting case reports out there about aspiration of gummy bears, which can cause respiratory distress when it ends up in the lungs. But even more interesting was this case report about a gummy bear bezoar, which I find impressive that they took that out of a kid. But my favorite thing here is the conclusion of it is that we don't just need to worry about gummy bears. We also need to worry about gummy fish, gummy snakes, and gummy rats. All right, so that was fun. Let's move on to Go Lightly, or polyethylene glycol. So this diagram here is from a survey done of anesthesiologists and gastroenterologists into what they think NPO time should be for a bowel prep. And no surprise that the gastroenterologists all say 2 hours, and the majority of the anesthesiologists say 6 hours. So a huge split opinion on this. Yes, polyethylene glycol powder mixed in water is transparent, but it is hyperosmotic, non-absorbable, and there is definitely concern that aspiration of that solution can cause respiratory distress, pulmonary edema, and chemical pneumonitis. But most of the case reports of aspiration of polyethylene glycol were actually associated when it was administered via NG tube, and it occurred before sedation or anesthesia occurred. Another concern about a bowel prep is that you're ingesting a really large volume of liquid. And remember, ASA guidelines say consider the type and the amount that is ingested. So it's thought that maybe because it's so much that it might increase aspiration risk. There was a recent prospective study that found that gastric residual volumes were found to be less than 20 mLs total, even 2 to 3 hours after drinking a bowel prep. So honestly, we probably still need a lot more evidence about Go Lightly to figure this out. But I think many of you said consider it 2 hours like a clear. It wouldn't hurt to err more towards 3 hours either, but probably 6 hours is a little bit too long. All right, let's bring up our next poll, please. All right, how many hours of fasting for oral contrast now? Is it 2, 4, 6, 8, or none of the above? All right, I'll give you a couple more seconds. And if we can go ahead and close that poll out and pull up the results. Oh, all across the board. Oh, that's really interesting. So about 22% said 2 hours, 25 4, 20% 6, 3% 8, and 32% said none of the above. Oh, that was all split. Very interesting. All right, so orally administered contrast medium, they use it to provide good visualization of the GI tract when you're doing a CT abdomen evaluation. And I'm married to a radiologist, so that's like super important to him. The small bowel transit time is on average 1.5 hours. So really the challenge in getting these studies under general anesthesia is balancing the technical factors to make sure that you can have good image quality of the study with our safety concerns stemming from the risk of aspirating, especially if you're anesthetizing a patient who's with a potentially full stomach. There have been reports of death from aspiration of oral contrast, as well as respiratory issues. Although it also has been shown that most patients who do aspirate oral contrast, it really just have mild to moderate events and they have no significant sequelae. So a study looking at gastric emptying of oral contrast found that residuals at 75 minutes were 50%, and at 135 minutes, they were 25%. So in general, I would say probably recommend, in the conclusion of the study, was to wait about 3 hours at least after administration of oral contrast before you proceed with the study. All right, next poll, please. All right, how many hours of fasting for chewing gum without swallowing? Would you do 2, 4, 6, 8, or none of the above? This should be a fun one. All right, let's see if we can go ahead and close out that poll. All right, so 28% of you said 2 hours, 3% said 4 hours, 3% said 8 hours, and 68% said none of the above. Awesome. Love seeing these results. So chewing gum, as you notice in some of those specialty society guidelines, some of them have them in their clear category, and that's just for chewing gum. That's not for swallowing it. And the reason is because there is evidence that chewing gum does generate saliva and ultimately would stimulate gastric secretion, which would be concerned for increased gastric volume. But most of the studies that I could find show no effects of gum chewing on gastric volume or pH. And there's actually some effects that it may promote gastric motility. The problem with gum is first, it can be swallowed, which in that case is considered a solid. But more importantly, is that it can be a foreign body. It can lead to an adverse airway event rather than increased gastric content. So this is a picture of an LMA that someone took out at the end of surgery with gum stuck to the bottom side of it. And that's because the patient had parked it on the roof of her mouth so that she could chew it after surgery, which I find very funny. But I've also heard about gum being stuck at the bottom of endotracheal tubes, and you're unable to ventilate patients as well. So it is an airway foreign body, and that is more of the concern about gum rather than, I think, the aspiration risk with it. If we can pull up the next poll, please. All right, now how many hours of fasting for chewing tobacco or dip? And I don't know how many patients you guys have in Wisconsin that dip, but we have quite a significant patient population in North Carolina that does. So this is an important one, at least for my practice. All right, if we can go ahead and pull up the results there. All right, all across the board. 2 hours, 26%, 4 hours, 15%, 6 hours, 21%, 9% for 8 hours, and 29% for none of the above. All right. So yeah, chewing tobacco, you may think that it is similar to gum. And so I showed you a lot of the evidence for what it's like to chew gum. The difference with chewing tobacco is that it is particulate. And it often is, even though people do spit it out, it can be swallowed a lot more. Particulate matter can be swallowed more than gum can. So my personal thought would be to wait more like 6 hours, but there literally is no information out there on PubMed about fasting guidelines or gastric emptying studies after chewing tobacco. So that would be, if someone wants to make their mark, that would be a good area to go into. All right, next poll, please. All right, now how many hours of fasting for tube feeds? Is it 2, 4, 6, 8, or none of the above? And I believe this is our last poll for today too.
I think we might have one more.
Oh, do we have one more? No, thank you. All right, fantastic. Tube feeds, 9% said 2 hours, 6% said 4 hours, 32% 6 hours, and 47% 8 hours, and 6% said none of the above. Very interesting. All right, so integral formulas, they often contain carbohydrates, protein, and fat. So depending on their composition, they may fit on the 6 or 8 hour categories for non-intubated patients. But I do want you to think about the common practice of withholding feeds for 6 hours before surgery and then waiting 2 hours after the surgery is completed to resume feeds leads to very prolonged fasting for these patients. And if you think about the majority of patients who are on tube feeds, why they're on them for nutrition, they may be ill, and this could lead to more of a catabolic state for them. So this is something that I really encourage you all to think more about if you have a patient on tube feeds prior to surgery. If the patient is intubated on tube feeds and they're going for non-abdominal or non-airway surgery, if they're going for surgery that is not on the airway or is not on the abdomen, really the risk of aspiration past the cuff of the endotracheal tube is quite small. So tube feeds could be continued up until the time of the procedure starting, or even during the procedure. In some institutions, they do that. But really, if you're doing airway surgery or abdominal surgery, that's when you want to be a little bit more cautious. So that's when the tube feeds should probably be stopped for 6 to 8 hours, depending on the composition. Another issue is the location of the tube. So post-pyloric feeds, it's thought that since nutrition is given distal to the pylorus, that there shouldn't be any concern for gastric residual volumes. So some people say that you can continue pyloric tube feeds up until the time of non-abdominal surgery. That being said, we really don't know if there's any evidence out there that a jejunostomy tube offers less risk of aspiration than a gastric tube. The other thing you have to think about is that the ASA guidelines, again, they're written for healthy patients, but when you're thinking about them in the context of a patient who needs tube feeds, the ASA guidelines are written about patients having meals, that's bolus feeds. So what about if patients are getting a continuous rate on their tube feeds? You got to figure out how much volume they're actually getting to decide when you might want to stop the feeds, when you want to weigh the risk and benefit of prolonged fasting versus aspiration for these patients. So I would say what is very important to do is to determine the location of the tube first. If it's surgically placed, if it's duodenal tube or jejunal tube, and if it's nasally placed, there's definitely less certainty in terms of the tip of the tube. Even if you get imaging, it can still move after the imaging study is obtained. So that's probably better to treat it as a gastric tube. All right, and that was a cute picture of a baby, because since as a pediatric anesthesiologist, I always have to have cute pictures of babies. So let's talk a little bit more about formula. There's a really awesome study that came out in anesthesiology this past year that looked at formula feeding in 46 newborns aged 0 to 5 days old. And they did gastric ultrasound before a baby was fed and then every 15 minutes after formula feeding. And they found that the emptying time ranged from 45 to 150 minutes with no differences between male and female newborns or with those that are born via vaginal or cesarean route. They found that gastric volume return feeding values at an average of 199 minutes. That's well under that 6-hour mark that we use in our current guidelines. And then when they compared preterm to full term, of course, they found that gastric emptying times were faster in full term and took longer in preterm. Pregnancy is another interesting area. We always think about pregnant women as being an aspiration risk, but most societies actually say that standard fasting guidelines should be followed for preoperative pregnant patients who are not in labor. Gastric ultrasound studies in non-laboring patients at term show that their baseline gastric volume, their fasting volume 6 hours after solids, and their gastric volume 2 hours after carbohydrate drink is not different from non-pregnant females. Once they're in labor, we know that gastric emptying is slowed even more, but starving pregnant mothers can result in increased ketoacidosis, which is not great. So we see that ketoacidosis is decreased when carbohydrate fluids and sports drinks are given during labor. So that is why ACOG recommends modest intake of oral clear liquids in uncomplicated patients. All right, obesity is another area where we think that patients probably have increased gastric emptying, but those who are just overweight or obese, who are not morbidly obese, again, standard guidelines should be followed as per most specialty societies. Gastric emptying of both solids and liquids is not actually delayed in obese patients in most studies. In fact, it is sometimes more rapid than normal weight patients. You should remember that a patient who's undergone bariatric surgery may have delayed gastric emptying. And then you also want to think about gastroparesis. If a patient does have gastroparesis, they may benefit from a longer duration of fasting on a case-by-case basis. More than 50% of people with type 1 or type 2 diabetes do have delayed gastric emptying. But when you look at the meta-analyses of all these gastric emptying studies in diabetics, there still is conflicting evidence regarding about gastric content or volume after fasting. So what overall are we thinking here? It's still, I probably confused you all more after this talk than before. So before I come to some complete conclusions, I do want to do some fun lessons learned here. Preparing for this talk, I got a lot of stories from other anesthesiologists about some weird fasting things or NPO compliance issues that had happened to them. So this is weird but true. My kids love this series. This is weird but true about NPO violations. One anesthesiologist told me she went to pre-op a 4-year-old was holding a chocolate chip cookie in her mouth, and the mom told her that, you know, she's just pretending to be Cookie Monster and wasn't eating the cookie. But we all know that a 4-year-old, even myself, can't resist eating a chocolate chip cookie. Another anesthesiologist had a man who put a rock in his mouth to suck on so that he wouldn't feel dry, and then he swallowed it. I'm not really sure what you do about that for NPO time. Patients who had last meals of dried dog food, roots, ears of corn, babies who had both breast milk and chocolate cake for breakfast. Just people eat weird things before surgery. Another fun thing, lessons learned from putting this talk together and all these stories that I heard. First of all, the words you use matter. So if you tell people no breakfast, you will have patients who show up who ate a lunch or a dinner meal first thing in the morning. Another funny story that someone told me was that the patient didn't eat breakfast, but he was eating the soles of his shoes when he walked in a pre-op because that was not breakfast. If you say no solids, people have a hard time figuring out what solids is unless you specify. Sometimes people don't think yogurt, avocado, or even potato chips are solids. Don't eat anything after midnight until you get to the hospital. Well, one patient who got that instruction decided to go to the hospital cafeteria right when they got at the hospital before their surgery. If you ask someone, have you had anything to eat or drink today? You can even hear patients who say no while they're holding a soda can and said that I'm just sipping, I'm not drinking. Or patients who say, or the families who say no, they didn't have anything, but they took their meds with, and I thought the weirdest thing I've heard was popcorn. I don't know who takes their meds with popcorn. That's very unusual. If you say nothing by mouth, some people will say, well, what about through my nose, like doing cocaine on the morning of surgery? And I thought this was quite an interesting story that there was a 3-year-old and the mom gave their child black coffee, apple juice, water, and Pedialyte all at appropriate times. And even though the kid doesn't normally drink all those things, the mom did it because the paper told them that that was what you should do. So needless to say, that kid was probably bouncing off the walls. This is personally a mantra that I live by. A child in a car seat will never be NPO. For those of you who have had kids, you know there's always tons of things that they find in car seats that you have no idea where they actually came from. Don't trust anyone. So at one story, someone submitted to me, they said that their hospital lobby had free hot chocolate and Christmas cookies during the holiday season. So when the patients arrived for their surgery, many of them partake that free gift before coming up to the pre-op area. A child who was being transferred from hospitals to get an operation for acute appendicitis, the ER gave them a popsicle. Probably not as big a deal because it's probably a clear, but you know, still they're going for surgery. Or a child life specialist who gave a patient peanut M&Ms to eat after surgery as they're heading down to the OR. Of course, the kid lay down. Someone else discussed an autistic patient that they swore was NPO, and then after they induced them, the nurse talked about all the chicken nuggets and French fries in the sheets. This was an interesting one. There was a kid who got canceled because the mom gave the kid prune juice in the pre-op area. And as that family was leaving, the next scheduled case was coming in. For some reason, the kid got the bottle of the prune juice, just grabbed it out and drank it as well. And then we always give kids things in pre-ops like stickers, Play-Doh that can get eaten. This is one story about a child who ate a sticker on a stuffed animal that was given in pre-op, and the mom said, can we please get an x-ray? The anesthesiologist was like, oh, I guess so, even though the sticker's not going to show up. But then there were a bunch of metal things in the stomach. So very interesting. And I'm sure many of you have a lot of strange NPO stories as well. So just to conclude for today, I do think we get so worried about aspiration, and it is extremely, extremely dangerous when the consequences do happen. But at the same time, it is a very rare event. And I think we do need to kind of switch the focus and think about what are the consequences of prolonged fasting on our various patients. As a reminder, our ASA guidelines, they are written to reduce the risk of aspiration for healthy patients. They do not apply to all of our patients and cannot prescribe the optimal care for every single patient. They are based on the best data that we have in the literature, but it is definitely insufficient. So I really want to encourage all of you to start thinking about your patients in a more individualized context instead of the hard and fast rules. We really need to use our expertise as physicians here to determine what's the risk-benefit ratio of allowing a patient to proceed, even if they technically violated our NPO policy. And what the adverse consequences could be if we do allow them to proceed. When we run into those really strange things, it's very important to look at the ingredients because a lot of them can vary, and use your judgment based on best science. This is not an easy task, but I do think this is an area that we could definitely improve our patient care by thinking about more on a case-by-case basis, rather than a lot of very strict guidelines. So I hope this talk maybe gave a little bit of clarity to some of you all about some of these strange situations. It probably brought up a lot of other questions too. So overall, I just want to thank you all for having me here today. It was truly a lot of fun. If you have additional questions, I know we only have a couple minutes left in the talk today. This is my contact information, my best email, as well as you can follow me on Twitter and Instagram. And with that, I do see a few things in the chat, so I'm going to stop sharing my screen and see if I can pull up that chat. We got the CME code in there. There is a couple questions in the chat that I can go ahead and answer. Yes, you can give glucose-containing fluids intra-op. That is very important and a great point to bring up, that even if you make a patient NPO, you can start them on glucose-containing fluids to kind of help with that aspect of hydration as well. And why not provide detailed written instructions preoperatively? I think that's an excellent idea, but not every institution does that. So at Duke, when we went through providing more detailed written instructions, there was still a lot of debate among our anesthesiologists about what we wanted to put on there, what we couldn't put on there. So yes, I think it is important to specifically name items and foods and drinks that patients should have, but even so, they're probably still going to have things that come up. Another question in the chat, what do we decide about chewing gum and chewing tobacco? So I would say to move forward, as long as a patient does not swallow the chewing gum, I think there's pretty good evidence to show that there's not a lot of aspiration risk as long as it is not swallowed. The chewing tobacco, I think that's still out there. I think because it's particulate, it's a little bit more challenging to me. That being said, I do think just like chewing gum, probably the aspiration risk is very small. So I don't think I have a good answer for that. I think that depends on a case-by-case basis. And with that, if there's any other questions that people would like to ask, either verbally or through the chat, I believe we just have a couple more minutes.
Thank you, Dr. Malinzak, for an excellent talk. It definitely was enlightening, and I'm sure we all have our various stories of NPO violations that have made us chuckle or frustrated us, given probably the time of the day.
Absolutely. It's one of the most fun things to hear about.
We do have a couple more minutes, but like I said, a lot of us are logging off in order to start cases.
Absolutely. I understand the rush to get to the OR. We actually have our grand rounds on Wednesdays as well. So it's very common, right at the end of the talk for everyone to log off. So I'm absolutely not offended at all. And I'm just grateful for your attention for so long today.
Well, I think that probably concludes, it looks like I'm watching the numbers drop. And so I think that probably concludes the talk. Again, thank you so much for joining us. We really appreciated your time and your insight. And I look forward to meeting you in person at one of the future meetings.
That sounds great. Thank you again. This was a lot of fun today.
Thank you.